This is Dr. Caroline Peterson in Natural Women's Health Institute in Sarasota, Florida. I'm here today to kind of show you how I work up a patient. So I'm going to start by listening to the body right here. Is it okay if I put my hand right here? Yes. Okay, so I'm going to touch. And then I do a little pump because I want to see how that sternum is moving. And so when I do this, I feel too much movement. I feel almost like I'm falling through. And so what I want to feel is like a springiness, like that. And so if there's too much movement and I'm falling through, the body's not pulling in one direction or another, then the next thing I do is listen to the back to feel what's going on back there. Why am I falling through into the back? I'm feeling like how well the back is moving. And so I'm feeling a lot of stiffness and solid. It feels kind of like concrete. I don't mean that in a mean way, of course. I mean that just like there's like probably like congestion or things are not flowing as well as they should. Mm-hmm. So I'm doing like little movements with my hand to try to, can you feel that moving over here? Mm-hmm. So that's the fluid, that's the lymphatic fluid that's moving from the right side of the body into the left side of the body. And so I'm gonna help clear that by coming up to the clavicle on the left side. And that's where the subclavian vein is. The left subclavian vein is where almost all the lymph fluid in the entire body drains. Can you believe that? Isn't that crazy?
That is wild. Our bodies are wild.
Our bodies are wild and wonderful. Yeah. And so we're draining that left subclavian vein. So I'm feeling in here. And it feels like it's kind of slowing down a little bit. So at this point I would go into the left axilla or armpit. Does that seem like it'd be okay for you?
Absolutely.
So this is only to your tolerance. So I'm going to put one hand under your back and one hand in your armpit. And this will help to get that subclavian vein opened up a little bit more. So we're getting a little bit more drainage. So I'm just going to move your shirt just a smidge.
Yeah, of course.
There we go. That's good. So I'm listening with my hand that's on your back to see when we find the right spot that's gonna promote drainage and movement, because that's what we want. We want movement. So I always start up here by the clavicles, the breastbone, the shoulder girdle, the collar region, because that's where everything in the body drains. And so we have to have everything draining in order to move other stuff. Otherwise, we're gonna get stuff that's not draining, receiving new stuff that's trying to drain and can't drain. And so then that leads to backup and pain. And that's no good. That is no good. So we try our best. Ooh, that seemed like it might be a little bit sore. I don't know. Seems a little bit ouchy. Ouchie, ouch, 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 ouch. So now I'm coming back to the clavicle, the subclavian vein, drain there a little bit. Yeah, that's starting, that's moving. Yeah. So it makes for kind of a boring video.
Just draining.
Just draining, but at least people get an idea of what's going on. There we go. Okay, that's moving. So I'm gonna come back and check the back again. See how that's moving? So that's much better. So that's moving much better. So now I'm feeling that the body is pulling up into the right jaw, so the right temporal mandibular joint. So I'll come up there, feel there. And here I'm feeling a lot of crying, a lot of sadness that's being held in this right side. And so we'll see if it wants to come out. So much. So there's this sense like of overwhelm, like I can't do this on my own, it's too much for me. And there's something in you that also kind of like recognizes, like I don't have to do this on my own. It's okay to lay down this burden. And so think about like really hearing that voice, that aspect of self that gives you permission to lay down burdens that are not yours to carry, even if historically you may have carried them out of love or obligation, duty, or even because you felt like you have had more like competence or ability than other people, just reminding yourself that there's no need to continue carrying things that don't belong to you, and that you can lay them down. It's not being mean. It's just, it's being healthy. It's taking care of yourself, and it's honoring the other folks on their journey. And entrusting them, knowing that they're strong enough to deal with the situation that they're in, and you can support in a way that's right for you, but you don't have to do more than your part, and you can know what is the right thing for you to do. There we go. Very good. Very good. Very good. Deep breath in and let it go. That's good. Here we go. All right, so that's moving properly. So I'm not getting a pull up or down. So I'm gonna keep following the breastbone down the midline of the chest. Checking the movement pattern, checking to see if there's a pull. So there's getting to be too much mobility here in the lower sternum. So we want to see why that's happening, see how it's kind of like, almost like squishy. Almost like too much fluid in here or something like that. There's too much squishiness. That a technical term? Is that a medical term?
It is.
Okay. Today it's all right. So we're gonna go to the intercept of the liver and the lung on this right side. And of course, the respiratory diaphragm is between them. And so we'll also be listening and addressing that respiratory diaphragm and the squishiness, which sometimes can be related to the mediasternum, which is right there under the breastbone. Sometimes it's not. There we go. But you can feel right back here. This is the azygos vein, which is trying to drain up. And so it could just be that it wasn't draining very well because there was like too much congestion further up. And so that's where the sponginess or the bogginess came from. There we go. That just released. All right, so now we're gonna go back and listen and check our work. I'm gonna come back to the midline. Perfect, perfect. Now see how that's not, do you feel the difference? That's
I
not.
do. Your hand doesn't sink.
Yeah, exactly. That's good. That's right.
Yeah.
So the next thing I'm going to do is listen to the front of the ribs. And we do that to listen to the kidneys. The kidneys are supposed to live back here. And we listen to the kidneys with, we listen for the motility of the kidneys. The motility, every organ in the body has some both mobility and motility. Mobility is the gross movement pattern of the organ. Motility is the subtle movement pattern that tells us how happy that organ is doing its job.
I hope very happy.
We want happy organs, right? And so the motility is actually reminiscent of the embryologic movement pattern of the organ.
That's pretty cool.
It's cool. So remember how all the organs kind of are like born and develop in different places, then they finally end up. And so, so that's what we're listening for. So like for the kidneys, for example, their embryologic movement pattern or motility is kind of like this. And they call it inspire, expire. And so it's kind of like a slow movement. And so when I put my hands on the front of the rib cage, that's what I should feel if the kidneys are happy doing their job. So I'm going to touch the front of the rib cage, and there it is. And they're moving pretty darn good. That's good. So there's a little bit of it feels almost like a click here. That's not directly related to the kidney. It feels indirectly related. And so I would go into this area because this is more like stomach, respiratory diaphragm region. So I would go in here and check that. So, because sometimes, you know, an organ can get kind of caught up on its neighbor. That's not ideal, but it happens sometimes. So we'll come in here. So remember that there are like 3 big holes or hiatuses in the respiratory diaphragm. One of them is for the esophagus that hooks up with the stomach, and that's kind of like where I am. The other hole is for the aorta, the blood that has oxygen in it. And then the other one is for the vena cava, which has the deoxygenated blood that's going back to the heart and lungs for oxygenation. And then there are a few other like small holes for things that go through the respiratory diaphragm. But here, there we go. That's perfect. That's very good. Okay, that's very good. And so now I'm gonna listen again on the rib cage. We'll see if that there we go. That's perfect. That's perfect. So I'm gonna listen on the front of your tummy. I'll use my hand there. So this is slightly pulling up into gallbladder and liver. So we'll come over here. And so the liver is in charge of the first two phases of biohepatic detoxification, right? Yep. And then the third phase is gallbladder. And then it squirts into the duodenum, yes, the intestines. And then the fourth phase is pooping it out.
Beautiful. The end.
So all those things have to work right. and so when I feel, so ideally, so this is your rib, the lower rib margin. Mm-hmm. And so what I would really like to feel is that the gallbladder is pretty close to there, sometimes even tucked in a little bit, mm-hmm, but not too far out. So right now I feel this is there's almost like maybe 2.5 inches of gallbladder out. So this is suggesting some congestion in the gallbladder. So the gallbladder can be congested for different reasons. So we'll check some of them. So this is where the gallbladder hooks up to the common bile duct. Common bile duct is what takes the bile from both the liver and the gallbladder. So the liver is constantly making bile because that's the breakdown product, mm-hmm, right? That is trying to get rid of all the toxins. And then it drips always, continually, a little bit at a time into, oh, there it is. Can you bring your pants down just a smidge? They're right on the OD, the sphincter of OD. There you go. So there's the belly button. And so the sphincter of OD is like right here. This is where the common bile duct injects or inserts into the duodenum, the first section of the small intestine. And so the liver is doing its drip of bile into the common bile duct. And then part of the bile is also going into the gallbladder for safekeeping. Ooh. Yeah, because it's it's like a little reservoir. So that when you eat, then the body's like, oh, there's some fat there. Boom. And so it sends a bolus, the gallbladder sends a bolus of bile into the small intestine because we need the bile. It emulsifies fat. It makes it water soluble. So we can actually use fat and absorb it. Cool. If the gallbladder's not working right, then we're going to have a problem with fat because we might not have enough bile in our system to emulsify it or make it water soluble.
Okay.
Yeah. So now I'm working with that common bile duct because one reason that the gallbladder can be a little bit distended, I'm not saying that it's something scary or anything like that, this feels totally functional, is if there's a little spasm in the common bile duct. And so so that just released the sphincter of OD. That's also where the pancreatic enzymes inject into the small intestine. So we need both the bile and we need the pancreatic enzymes to be able to digest food in that small intestine.
To do what they do.
To do their thing! Yeah. And so now I'm kind of like, I call it milking that common bile duct to help it kind of like relax and so it can transit the bile through a little bit better.
Okay.
So you can feel there's a little bit of stiffness here. It's not too bad, but it's just enough to be like, oh, you know, I was kind of like holding against that little tightness in the sphincter of OD. And so then, you know, these tubes are muscular, right? They're made out of muscle. And so it's kind of like getting a little massage, you know, when you have a tight muscle or something like that.
Yeah.
Yeah, so that's good. That just released. And so now we can come to gallbladder. So we're going back to where the gallbladder hooks up to the common bile duct. That's pretty soft. And so now I'm going to go into the gallbladder itself. And so that could be a little bit sore. Sometimes working on a gallbladder that's a little bit congested can be kind of sore. So the other reasons that the gallbladder can be kind of like congested or distended is sometimes we're moving through life too quickly and we're not.
I don't know what you mean.
It's a foreign concept. We're not taking time to sit down and plan our meals and anticipate the food and enjoy each bite and relax afterwards or take a little stroll.
Mm-hmm.
Like, that's not part of our culture, right?
Not really, no.
But that's the way that our body's built. Our body needs that.
Okay.
Yeah, because what happens when we do that form of eating, then of course we're turning on the autonomic nervous system, parasympathetics, right?
Mm-hmm.
And then they're like, good, I like to eat.
Happy.
And then it tells the belly, the stomach, I mean, oh, we're gonna get some food here pretty quick. Start warming up, and so then, the stomach is prepared and it's gonna start increasing the acid that it needs to, like, for that first phase of digestion. And then when that acid level goes up, that gives a signal to the gallbladder, like, we're getting food, so you gotta get your squirt going. Get your squirt up ready, because it's coming. So that's a big part, why people in our culture get congestion in their gallbladder.
Okay.
Of course, a little bit could be, things like, they're not eating high quality food, and so then the gallbladder's like, what's the point? And so then it's like it doesn't get the message, and so then the bile is just kind of sitting in there, and then the water kind of is reabsorbed, and so then you get this kind of like paste in there.
Okay.
And then if there's paste, then the body's like, oh, that's too hard to push out. Ugh. And so then in that situation, what we need to do is add in like bile thinners, like beet or bile salts, ox bile, some different kinds of thinners to get that bile moving again, moving and grooving. Yeah, because if we don't get it moving, that's when people tend to get gallstones or porcelain gallbladder. Have you heard of that one?
No.
Like a toilet is like porcelain.
Yeah.
That's kind of like what happens to the gallbladder.
It just hardens.
It hardens up like a toilet.
No.
That's terrible.
That is
What's
pretty
that?
terrible.
Nobody
No.
wants that. No,
Not today.
no, not today. But are we willing to slow down?
Yes.
We are. You are.
We are.
That's awesome. That's awesome. Yeah. All of us should be, huh? And you are. That's awesome. Yeah. So that's undoing. So the other thing that can help a lot with this is like bitters at the beginning of a meal, or like apple cider vinegar or something like that. And if you think about it, a lot of cultures start their meals with that kind of thing. So in Portland, there was a street Thai food restaurant, a few of them, that had the sipping vinegars. Have you ever had those before?
No.
And I think they make shrubs out of them. Is that right? Is that the right word?
I don't know.
But so in some Asian cultures, like, people just sip vinegar before their meals.
That's pretty cool.
Or, if you look at any movie from the 50s and 60s, then you're going to see everybody having a cocktail with bitters before their meals. Have you ever watched Bewitched or anything like that? Or I was like looking at old videos, and it was showing, oh, this is the way we set up our TV. Here's the TV and here's the alcohol. They go together. Had no shame. They were just like, oh yeah, I got my TV and my bitters, and this is the way we do it.
That's so funny.
All right, so we'll let that one go for now. That's better. It needs a little more work, but I think probably for the sake of the video, maybe we'll let it go and come back to it. Remember, the liver has two lobes, And it's actually like a gigantic organ. Like nobody can believe how big it is. Like how could such a gigantic organ fit in such a little person? But it is. It goes like 3/4 of the way across, your rib cage. Can you believe it?
No.
Most people think, oh, it's just gonna be on like this right side, just here a little bit. No, it's big and huge and gigantic. And so, so if there's any kind of like inflammation in the past, low detox or a high carbohydrate diet, or those are the alcohol, stuff that makes fatty liver, basically.
Like antibiotics?
Yeah,
No.
anything. Let's say that you're taking in more toxins than you're able to
Got it.
detox. That would all create kind of like a sluggish liver. That's sticky, like a sticky liver. Low B vitamins can do that. A lot of things like that. And so this feels just like. It feels like a constipated liver. That's not, maybe that doesn't sound very nice, but it feels like it happens to everyone, right? So it's not a personal. It just feels like the liver is kind of like struggling. It's like, where are my bitters? I need dandelion. Where is my milk thistle? I want some turmeric. It just feels like it's wanting a little bit of TLC.
You got it.
And so it's totally normal. Like if you think about it, like the way that plants grow, in the spring, all the bitters come out. And so in the olden days, when people lived off the land, they were like, okay, we're eating this because we don't got anything else, right? And so everybody automatically did a liver cleanse in the spring. And so we've gotten away from that because we're not dependent on the land anymore.
Yeah.
But our bodies
Still
still need the same things. Right there. That's it. Right there. Right there. Are you okay with that pressure?
Yeah.
Okay, so now I'm gonna keep putting pressure on here and release it suddenly. And so that's something, have we done that before? And so you'll remember that that's something that doesn't hurt, but it is surprising when I release it. You can ask me to release at any point. And what you'll do is take normal breaths through an open mouth, and I'm feeling for the organ to call into itself, and then I'll release it when it's all engaged. So it'll be surprising, but it shouldn't hurt. You can ask me to stop at any point.
Okay.
Okay. Take a few more breaths.
Yeah, not painful at all.
How are you doing?
Good.
Alright, go back and listen again. So that's moving better. That's moving better. Yeah. So this in the olden days, and in my medicine, I learned it from my abdominal therapy. So it's called a blood stop. So Don Eligio taught my teacher Rosita this. And so the idea is to prevent blood from flowing and then release it suddenly so that the body goes, oh, yeah, this is my normal. Oh, that feels much better.
It
Like
does. Yeah.
Yay. I'm gonna listen down the midline. So I'm gonna check here for the possibility of hiatal hernia if that reflex is not active. I check the pylorus right here, which is where the stomach hooks up with the duodenum, the first section of the small intestine, and that's a little bit tight, not too bad, a little bit tight. There we go, that just released. And see, do you remember how before I was like, my hand was being pulled way back? It's not like that anymore. So that's super awesome. So because the uterus is lifted up a little bit, then what we're gonna do is go into the bladder and see if the bladder will lift. So remember the bladder connects to the pubic bone it connects to the sacrum in the back of the pelvis, right? And then it connects to the side walls of the pelvis and a few other places. It even connects to the belly button. Can you believe it? And so,
No, I can't. That's so
yeah,
cool.
it connects to the belly button through what we used to pee out of when we were a tiny baby inside of our mom.
Okay.
And that urachus turns into a ligament. And so that's one of the main ones that lifts the bladder. And so if the bladder's low, a lot of times it can be that ligament that's not lifting properly. And so then we do core strengthening to bring that up. So I'm going to come down to the bone. We're going to check the bladder connecting. Can this undouble a little bit so I can? That's good like that. Yeah. So there's a bone, and there's the pubovesical ligaments. The vesicle is another name for bladder. Okay. Of course, they have to call things the fancy name. And so especially the left side is kind of like a little bit pulling.
Mm-hmm.
So these ligaments actually like move every time you fill your bladder. They're kind of like this when the bladder's empty, and then they have to stretch as the bladder grows. and so we just want them to be pliable, right? So that they can have that capacity to move as the bladder fills and empties. So we're working with the pubovesical ligament on the left here. There we go, that's good. So I'm gonna come up, I'm feeling for those supporting ligaments. And so this right here, this is where the ureter inserts into the bladder. And so I'm gonna follow it because sometimes the bladder is a little bit droopy because, you know, the surrounding structures are not set up right. And so we need to get that. I call it iron out the ureter, which is the tube that goes between the kidney and the bladder.
Yep.
And so if you had a kidney that wasn't moving properly, like I think a while ago, we might have worked on that, then sometimes that ureter just needs a little bit of help coming back on board. Yeah. So we'll just iron out this ureter a little bit. I don't even know if people know what irons are anymore. Do people know what they are?
I know what one is.
You do. That's a secret. I don't even know the last time I used an iron. There's probably a better way to say it than ironing out something. Okay, I'm gonna come back to the pubic bone. We'll check that. Okay, that pubovesical ligament is good now. That ureter is good now, and we have a little bit more left. So this is something we would come back to and work with in more 3 dimensions later on.
Okay.
So now we're gonna check the ovaries. So remember that my body's the uterus, my arms are the fallopian tubes going back for the ovaries. They're all connected, right? The fallopian tube is connected by connective tissue to the ovaries. And so the uterus has one thing in mind, it has one track mind, I always say that. Wants to have a baby. That's the only thing. It doesn't care about anything else. If you have one working ovary and one working fallopian tube, she'll be like, she goes all the way around. How can I find that egg? I gotta get it.
Yeah.
She'll do whatever it takes to get that egg, right? And so that's why I say I don't work on the uterus first. I have to check the ovaries first, right? Because if the ovaries are down here, you're never gonna get a uterus lifted up because she's like, I want my egg.
She's looking for them.
Yeah, she's looking. And she doesn't care if you're postmenopausal or whatever. She's like, I'm hopeful. Maybe I can have another baby. She's just that way. That's just the way she was born. So now I'm gonna come back to the pubic bone and come up to the uterus where the fallopian tubes are and follow them to see where the ovaries are.
Okay.
So I'm going to touch the pubic bone again. So there's the pubic bone. There's the top of the uterus, and this is like the isthmus, or where the fallopian tube on this right side connects. And so like this, your body is just like, where's my baby? Like, it's just kind of like, it's like getting a little bit dogmatic, I would say.
Okay.
It's like,
That's not
my baby, it is time to have my baby. It's a little bit grumpy, not in a bad way, but just like, I would say like in an insistent way. And so this feels like ovary perhaps, so a little bit low. And so there's the isthmus. And so then what we would do, so I always say, you know, the in my abdominal therapy, they say, you know, the uterus is the queen of the body. The uterus needs to be on her throne in order for the woman to feel great and in her power, right?
Mm-hmm.
And she loves to be like dressed and have people do her hair, put on her makeup, and really, you know, if you think about like, I think it was it Queen Elizabeth I that she was like carried around on all of these like platforms and stuff in the olden days.
Mm-hmm.
Oh, the uterus loves that. Oh, just move me to where I need to be. I'm a busy lady. I'm very important. And the ovaries are not at all like that. The ovaries are like, don't touch me. They're like, I'm the handmaiden. I'm going to be at the side of the queen, but you need to roll out the red carpet for me. So they don't like you to kind of manhandle them. They're just like, I will proceed, just roll out the carpet. And so if you put too much pressure on the ovary, they'll just be like, stop that, I have precious genetic material. So they'll always like, you know, let you know.
Mm-hmm.
They won't let you get carried away with anything. And you'll feel it. You'll be like, don't do that.
Okay.
It feels bad.
It doesn't feel bad right now.
No, because I'm not manhandling them. I would never do such a thing.
You would you would do no such thing.
No such thing. There we go. So that's going. So again, it's almost like a pining. Like your body's just like, where's my baby? Where's my baby? Like there's a need, there's a felt need of this ovary. So sometimes when the ovary is not moving very quickly, it's because it's actually connected to the cecum. Can you believe that? In about 70% of women, there's some connective tissue. There's a ligament called the ligament nuclea that connects the ovary to the cecum, which is the little pouch right here.
Mm-hmm.
That's the first section of the large intestine. And so sometimes if I'm feeling like, why isn't that ovary like moving in a way I would expect it to, then I want to check the cecum. Go into, like, I have the ovary here and the cecum here. And so now I want to see if maybe they want to move together. Yeah, they're related. Can you feel that? They're like, we needed to move together. We're in concert. You can't move one without the other. I felt that. That's cool. I'm so glad. That's awesome. That's awesome. Yeah, it's neat. That's what I always say, interoception, right? That's a form of feeling that a lot of us are not well practiced at. And especially with our organs, we're used to feeling our joints or our muscles, but most of us are like, cecum? What is that? Where is that? But then once you know, you now know what it feels like and, you know, all that kind of stuff. And people will feel like, oh, I can tell the difference between muscle and lymph and vein and artery and, you know, all the different forms of sensation that the body has. And then a person becomes much more specific. They won't talk about like pain. They'll talk about, you know, discomfort or tingling or fullness or, you know what I mean? Like it's just a different vocabulary develops as people become more deeply embedded in their body. It's really lovely, right? Because it's a way of claiming yourself. Yeah. This belongs to you. This is your territory. You're the queen.
Kind of, yes.
You are the queen, lady. You are. All right, so now we're going to come back and check. So I'm going to come to the bone, bladder, uterus. So you can feel, I don't know if you can feel, but I can feel on the right side, the fundus or the upper part of the uterus is coming forward. So that's correct. And then the ovary is pretty much where it should be. Let's start by explaining how I assess the uterus and the position of the uterus. So let's say that my fist is your pubic bone. The pubic bone is the bone in the front of the pelvis. And so what I do is I put my hand on top of the pubic bone, and then what I should feel when I palpate is that I go into a little valley, up a little hill when I'm checking the uterus. So remember, let's say my body is the uterus. And so the pubic bone is here in the front, and then the bladder hooks on, and then the uterus should be in slight anaflexion, like that, kind of leaning over a little bit. And these are the fallopian tubes, and they're going back to the ovaries like that. And so that's why when I feel the pubic bone, I go into a little valley, up a little hill. The uterus should be in slight anaflexion. If I don't go up the little hill, then she's not. And so now I'm going to touch the bone in the front of the pelvis. You can put your hand there to show me where it is. There you go. So I'll put my hand where yours is.
Okay.
So there's the bone. So I'm feeling puffiness. So what that means to me is, of course, there's a normal amount of puffiness to the mons pubis, which is there on top of the pubic bone, but it's a little bit more than I would anticipate. So that's already telling me that there's some drainage that needs to be happening that's not happening. And so that's something that we'll take care of, but I can feel that already. So we'll see if we can, sometimes if there's too much fluid, then it's hard to fill the organs. So we'll see if we can fill the organs, even if there's a little bit extra fluid around. Okay. So there's the pubic bone. And so here's the bladder. So the bladder, I would expect to go up a little higher. The bladder's like right here. I would expect it to be right there, which probably doesn't feel like a big difference, but it's a tiny little bit. So to me, it feels like the bladder's a little bit low, and probably even, you know, people can have a bladder I'm very picky, and so I want things to be kind of like ideal. And so the body's very flexible, very competent. It can be like, I can still make do. I'll do my best. The body's always like that. It doesn't need the ideal. And so I always try to do the ideal because you just feel better.
Yeah.
And so there's the pubic bone, there's the bladder, too low. And then when I go to the uterus, there's no up the little hill. It's all retroverted. And so that's like what I was saying before. When I was feeling, I don't know if you can feel it, it's like my hand is being just like really pulled back to the, I mean, it looks like I'm exaggerating, but it actually feels like that to me.
Yeah.
But of course, it's not pathological or bad or anything like that. Like, you're like a beautiful woman and everything is like great, right? And so this is just like part of my experience of the organs in the body.
Yeah.
Where the organs are like, oh, that's not my ideal. That's basically what it is.
Got it.
And so the uterus feels midline, feels a little bit inferior, and retroverted. And so remember that slight anaflexion is the normal position. We call it the normal position of the uterus. But of course in biomedicine, their idea is like, hey, any position is totally fine as long as the uterus is not falling out of your body, right? And so we're a little bit more picky than that. And so if a uterus is retroverted, like yours in the midline, it means that she's pulled back like that, just kind of like angled back.
Okay.
All right. And so And so now we have an idea of what's going on with the uterus.